Jitendra, you can start off by the welcome address.
Yes, yes.
3, 2, 1. So we are live now. We can start our session. Over to Jitendra sir.
Okay, thank you. So good evening to everyone, and we wish you the happy Independence Day. Myself, Jitendra Patil, and I'm working with Oaknet Healthcare as a head medical marketing and head for one of our dermatology business. It gives me a great pleasure to welcome you on behalf of Oaknet Healthcare for today's scientific webcast on recent advances in the management of urticaria by our Indian expert, Professor Dr. Kiran Godse, and international expert, Dr. Torsten Zuberbier from Germany. To brief you about the Oaknet Healthcare is an emerging and fastest growing pharma company. And we as a company dedicated to the field of dermatology and cosmetology with our focus area, urticaria, melasma, psoriasis, and superficial fungal infections. So as you may are aware about the prevalence of the urticaria is increasing, and compared to the last decade, the prevalence is almost double. And the objective of this webinar is to discuss the recent advances in the management of urticaria and the Indian experience with the current treatment in the management of urticaria and Indian guidelines. So for today's webcast, we have our Indian expert, Professor Dr. Kiran Godse. So Dr. Godse is current president of IDVL, and he is professor of dermatology at D.Y. Patil Medical College and Hospital, Navi Mumbai. And he is also the member of expert group of dermatology section of EAACI, Galen, EDF, and WAO Urticaria Guideline. And Dr. Godse has more than 75 publications in Indian and international journals. He is also the recipient of IDVL oration on urticaria, and he has been the special interest group urticaria coordinator. And our international speaker is Dr. Torsten Zuberbier. And Dr. Zuberbier is a German dermatologist and allergologist, and he is head of the clinic for dermatology, venerology, allergology at the Charité University at Berlin, which is one of the Europe's largest hospital. And Professor Zuberbier is having the clinical research focus on urticaria, food allergies, and allergic rhinitis. And he is assistant editor of the Journal of German Dermatology Society and member of the scientific advisory board of the Allergo Journal. And he is also the part of the clinical trials of the bilastine in the management of urticaria. And he is also the member of expert group of dermatology section of EAACI, Galen, EDF, and WAO Urticaria Guidelines. So I request Dr. Zuberbier to start with our first topic, that is management of urticaria and recent advances. So over to you, sir.
Thank you very much, Jitendra, for the nice introduction, and it's a great pleasure for me, at least to be online with you on your Independence Day. I wished I could be there, and I do hope everybody finds a short time solution for this corona problem, which we all face together. I will share my screen now with the presentation, and oops, just the right screen. So you should be able to see my screen. Is that correct?
Yes, we can see it.
Wonderful, wonderful. So management of urticaria, recent advances. I've been working on urticaria since 1990, heading the guidelines for a long time. And I'm simply devoted to this disease. It's such a fascinating thing. However, first of all, I have to mention my conflict of interest. I have been working together with many companies, including also the company originally developed bilastine. And in addition, I'm also head of the European International Allergy Foundation and president of the Galen Network, the Global Allergy Network, which is actually has been started in Europe, has been involved in the guidelines all the time, but also has sub-networks spanning the globe. And my good friend, Professor Godse, is really in Mumbai, the person for India, heading our Galen areas and our Galen work over there, not only in urticaria, but also in atopic dermatitis and other allergic diseases. So this is really fascinating. This is a good way to get exchange. Looking at the urticaria disease, and already 10 years ago, my friend Walter Canonica and his group in Italy looked at the impairment of urticaria. And many people think, well, yes, it's maybe people are afraid to eat. Maybe it's itchy, they don't really feel well. You can't sleep very well if it's itchy. But I think this is really important. 84% of our patients feel embarrassed because in our modern world, in Europe, in India, everywhere around the globe, the way you look gets more and more important. If you suddenly have a swollen lip, a swollen eyelid, some wheals where it's visible on your face, you don't feel good. And people are afraid it can happen at any time. It's nothing you can predict. You sit there relaxed in a meeting like this. I could be talking now in front of all of my Indian friends over there. Suddenly a wheel comes up, a lip starts swelling. What shall I do? Luckily, I don't have urticaria. And luckily, if I had urticaria, I would know what to do. But people are afraid, and this is something we need to know. And of course, if you have histamine flooding your body, you cannot concentrate, you cannot work very well. This is a picture of the lecture hall. We have been sitting together, and I have to find my friend Kiran. Kiran, where are you? Somewhere.
Front row, second from the left.
Front row, second. There you are. Good. You remember, Kiran?
Yes.
Great fun. We were discussing the guidelines. We had a panel spanning the globe, all societies, 42 societies. But everybody in the audience was voting as well, green and red cards. Make sure that we have solutions which are practical. And it's a huge challenge. Everybody is aware that the healthcare system in Germany is one of the richest. And everybody is aware that also in India, there is a huge difference. There are a high number of people in the middle class who have more available funding for treatment, and there's a high number of people who are extremely poor, and you need solutions for everybody. So we have to think about solutions, and I'm very happy that Kiran, you will also talk about the Indian perspective at the second part of this meeting. Now, it was published 2018, Allergy, and I can say this is my hand. It's the first time, at least my hand was on the cover of Allergy, inducing physical urticaria, inducing symptomatic dermographism. And what you see is the so-called Frick test. You can see the different pins here have a different size and a different pressure is applied to the skin, and this stroke gets a different strength. And this means you can determine the threshold. Very important later, if we look at our treatment, we want to know, is it good? Is it not good? Of course, everybody wants total relief of symptoms, but not everybody achieves that. We want to know for everyday life in inducible urticaria, is this okay? Is this sufficient? Just a very short glimpse into that. I know all my friends listening to me over in India, you are dermatologists, you are allergists, you are specialists, and you are very, very knowledgeable. I know that from the many times I've been to your country, and I've always enjoyed it. The very many critical, clever questions I got. So we have chronic urticaria, the chronic spontaneous and the inducible forms. Many people always only talk about spontaneous urticaria, but in fact, inducible urticaria can be as annoying as the other set. Also, one more word. Urticaria is defined by the, actually, I'm sorry, it's always on the top. This is getting, you see it as well. I don't know why, maybe I should keep my fingers off the mouse. So it's defined as wheals angioedema, or both. And this is very, very important. The majority of swellings is also histamine induced. Of course, we have hereditary angioedema. Of course, we have also symptoms which look like wheals, like in vasculitis, like in lupus, like in Muckle-Wells syndrome. But the majority of both wheals and angioedema is really histamine induced. And the easiest way, a wheal, if it's histamine induced, it should go away after a few hours. At the very latest, that's the definition, 24 hours, but normally a few hours only. And if it stays longer than a few hours, longer than even 12 hours, this gives me the idea, well, maybe we should take a skin biopsy and look at signs of more profound, more deeper inflammation, more signs like going into vasculitis, maybe a high neutrophil influx. This is interesting for the special cases. Angioedema, if it goes along with wheals, clear decision, no reason to go into diagnostics for hereditary forms. If it's alone, well, it may be important to rule out hereditary angioedema or ACE inhibitor-induced angioedema. That's easy with history. But in the majority of cases, the treatment is the same. So what do I want you to remember, getting the background, getting the feeling for the treatment, which I also tell my patients. There are some special things about this histamine flooding the body in urticaria, something special about the skin in these patients. It's a very interesting slide. It's actually not on skin, but on allergic rhinitis, but it shows that the H1 receptor is upregulated if histamine is around. And this is extremely important. We often have the symptoms in our hay fever patients over time at the end of the seasons. The symptoms gets worse, although the allergen load gets lower. This is extremely important in urticaria also to remember. If the histamine receptor is upregulated by the ligand histamine, it's very, very, very important to keep a consistent treatment, not on demand. Many of my patients, if you don't explain it to them, they've been seeing other doctors, they always took antihistamines on demand when the wheals are there. This is stupid, very stupid. An antihistamine can only block upcoming wheals and never get rid of existing wheals, because this is just actually lymphatic vessels doing that. But more important, if you want to balance this, and I use this word with my patients, balancing this inflammatory response, making the system calm down, you need a persistent treatment so that the histamine receptor cannot get upregulated all the time. And this is also in asthma. This is from Walter Canonica, the original idea. In asthma, there is a minimal persistent inflammation. And if you really want to treat well, we need to treat above the visible symptoms. In skin, it's easy to see on the skin wheals coming up. But if you ask your patients, they often have this, what they call a twitchy, itchy feeling, not really itching, not yet, but they have the feeling of irritation. They have the feeling something is moving in the skin, something is coming up, something is simply not normal. And that's this minimal persistent inflammation going on. And again, the message here, treat continuously. Don't treat on demand. I like to share with you this insight. That's also very interesting, pretty new pictures showing that the itch-scratch cycle leaves impressions in the brain. It shows that the worse the urticaria is, the more the brain is already changed and anticipating the next itch. Something similar what we see actually in our atopic dermatitis patients where we have this itch scratch cycle. The only difference with urticaria, they don't scratch until it's bloody. In urticaria, they're more like rubbing the skin. Anyway, it doesn't really matter, but important, what it does matter is if you don't treat continuously, you will stick with this impression in the brain, expecting, anticipating the next round of itch, and then it's really too late. You need to be proactive, like in atopic dermatitis. Start treating before the symptoms are there. Keep treating. Symptoms should not come. Management. If we go into the details of the management, I want to make a short reminder of the diagnostics. We have very few suggestions to do in chronic spontaneous urticaria, but I want to mention a very few of them. Normally, we say diagnostics in chronic spontaneous urticaria, just do a differential blood count, see if there's parasites, eosinophilia, see if there's severe infection, looking at CRP or ESR, but then patient history, go further. In countries like India, infectious diseases, of course, parasites, hepatitis can be pretty often one of the factors leading to urticaria. For us, it's often Helicobacter, but it's actually not Helicobacter itself. It's the inflammation going along with that. I've recently published that with Russian friends, where we could show that if you treat the Helicobacter, the urticaria does only go away if the inflammation, the gastritis, the reflux in the esophagus is also treated. If it's not also treated, then the urticaria simply remains independent of having treated successfully the germ. So we need to learn more about these infections, about minimal inflammations. And I can imagine, and maybe Kira, you can comment on that a bit later, that also gastritis, reflux is not uncommon. In India, you have very spicy food, and this could, of course, be relevant in some patients. Now, food allergy is not a real cause for urticaria, but urticaria patients more often have food allergens on prick testing. This means we often have a comorbidity, but it's not the cause for the urticaria. Another question is, I always like to discuss that if I'm in India, pseudoallergy. We have a real allergy, everybody knows that, IgE mediated. We have pseudoallergy, and pseudoallergy is a little bit different. It takes some time if you have an elimination diet to get better. It takes some time to get symptoms if you eat something. The actually typical source for a pseudoallergy would be aspirin. The aspirin intolerance, you can often see wheals coming up after a few hours after an aspirin tablet, and then holding on for a few days even. Now, what we have done looking at pseudoallergy in food for a long time, since the 1990s, and we in the 90s already developed this diet, which is interesting also for India, because you're in the lucky position. You've got all this nice spices. You've got all these nice, sweet, good, sun-ripe vegetables, fruits, everything. And in these, there are apparently ingredients apart from preservatives, which also can cause pseudoallergies. And I also know, of course, you have a more humid and more warm climate, so there are more preservatives also required in some food items, which you have in India. And actually, this diet has been tried only in open label studies. It's extremely difficult to do a double-blind placebo-controlled trial with the diet. And this is the reason the US Americans always say, no, it's not really there. But in more than 1,800 patients, all the trials could show the benefit on the individual level, not on everybody. But the improvement level depends on the symptoms. It only works in chronic spontaneous urticaria. It only works if there's more or less daily symptoms. Otherwise, it's not the right patient. Interestingly, it's it's the food items where the aromatic compounds are in, like tomato. Tomato, you have 70% of those responding to diet, they react to fruits, to these typical sun-ripened fruits. And that's where actually India comes into play, where you have all the luck that you have all these really, really good tasting food. What's the background? And here there's interestingly something closing the circle to what we talked about before about the Helicobacter and the gastritis. Actually, what we do see, those patients where there were responders, they all had what you see on the left side of the screen, they all had changed, impaired, broken permeability in the gastroduodenal tract, whereas the non-responders to the diet had an unchanged gut mucosa barrier. Interestingly, 3 weeks diet changed these values back to more or less normal in everybody. This means that we are not quite sure, is it inflammation then causing this pseudollergic reactions, causing the urticaria, which would be in line with the data also for the Helicobacter study, which I told you about? Or is it the food item only? It could be that some of these pseudollergic aromatic compounds, like in ripened tomatoes, that they also have an impact on the permeability. Well, questions for further research, but what we can say, it's a cheap way of helping patients getting rid of infections, looking at the permeability, looking at pseudoallergy. Well, on the other hand, what about inducible urticaria? Here it doesn't work. Only test for the threshold, which helps you, like I showed you the Frick test, to understand how much treatment you really need. How much treatment do we need? If you ask the payers in Germany, they say, well, it should be sufficient. That's what they call it in the law, but they don't define what is sufficient. The guideline is pretty clear on that. We say, absent of symptoms, treat the disease until it's gone, or in a more sophisticated manner, we say, we recommend aiming at complete symptom control in urticaria, considering as much as possible the safety and quality of life of each individual patient. There is a bit more to that, not only to keep patients happy, to make them feel good. Of course, we want that as doctors. I strongly believe, although there is no long-term trial, but I followed up a lot of our patients on complete control with antihistamines, that this can be disease modifying, and we are going to talk about antihistamines now in the following part very soon. As soon, and that is the background to that, as soon as the system gets quiet, gets calmed down, gets balanced, then there is a good chance the histamine receptor turns back to normal and it all heals out, apparently. So we do have this algorithm. It doesn't mean we are not able and allowed to treat with anything else, but this is the algorithm of the treatments where the knowledge, where the evidence is best for. Starting with second-generation antihistamines, if inadequate control after 2 weeks or earlier, depending on the patient, increase dosage. If not, go on to omalizumab. If this doesn't work, change to cyclosporin A. I am fully aware that this is a question of money also, and we will talk about alternatives a bit later. But I want to start with antihistamines. Antihistamines for me are not only the mainstay, antihistamines are also something where I say, I have a full trust in these drugs. Patients sitting in front of me, they say, hey, doctor, I don't like to take tablets. Well, I say, no, if you take an antihistamine, it's rather not a tablet in the old way. We do know this compound. It's only balancing the system. It works like something put into the socket so that the plug doesn't go in, that the histamine can't really activate your system, and that it simply calms your system down. And really, no, it's been used for hundreds of millions and millions and millions of people. Not a single long-term side effect has ever been observed. But it's partly true. It depends a little bit. There are side effects of antihistamines, and we have this ideal antihistamine properties defined by the World Allergy Organization: potent, selective, rapid, long duration of action, efficacy in rhinitis and, of course, urticaria against all symptoms, no interactions, no sedations, no other receptors activated, anticholinergic not activated, no cardiac safety concerns, and no tachyphylaxis. Actually, tachyphylaxis is not a problem in any of the antihistamines. If you look at that, then, of course, and that's why second generations are recommended, we have a long-term history of the development. Originally, these were rather antidepressant agents, which were found more or less by chance, and old drugs like chlorpheniramine are still around, and actually also other old sedating antihistamines are still around. The right side, the second generation and the newer second generation, bilastine is the newest. It's the most advanced. It's like if you take a car, the Mercedes from 1937 certainly looks different from the Mercedes from 2020. And we have this long-lasting research knowing more and more and more about diseases and drugs. And if you look at bilastine a bit more closely, it's non-sedating. And that's important. First generation antihistamines are not recommended because, well, you can say they have these interactions with other receptors, maybe cholinergic. That's not the most important part for me. For me, it's the impairment of cognitive functions. Many of my friends in pediatrics, but they sleep so well, the baby, it sleeps and the mother is happy. No, I say, you're putting that baby into narcosis. You could as well use a narcotic, you could as well use whiskey to quiet that baby. That's not good. So important is the message that an sedating first generation antihistamine has an impact on the sleep phases, REM sleep phases. You all know they are extremely important for learning, for actually recovering the brain overnight, and also for being alert on the next day. And first generation antihistamines have a very similar property like alcohol. They make you sleep very quickly, but they change the sleep pattern. And that's actually what makes me most or I would say careful. It's no problem using a drug like hydroxyzine in certain instances, but if you want to use it for a long period, a drug like bilastine is simply much, much better. First generation overdose, while that happens, I'm not so afraid about that, but there have been several intoxications and people actually dying out of overdosages. This is not possible with the modern antihistamines, not possible with a drug like bilastine, because the problem was not the histamine receptor, but the other receptors, which are also actually activated with these old drugs. So there's one more difference also. While modern antihistamines don't have these negative side effects, they also have one beneficial effect. Further, they also control late-phase cytokines released by the mast cells, and that's something where we really also aim at if we want to go into full symptom control. Now, what do I choose? We have different receptor affinities, and bilastine is certainly the strongest, the best here. We do have this, which is key for me, bilastine is the only one really non-sedating at all, not passing the blood-brain barrier. And you see on the lower part of this graph, ketotifen, which is really going into the brain 75%. And this can't be good. You need your brain. And even if you get accustomed to that, it's like getting accustomed to drinking beer all day long. You get accustomed. You all know there are people drinking beer all the time, but this is not good. Sorry. And now, if you look at that further, this can be shown. Bilastine also in higher dosages does not have any effect on the way, for instance, you drive a car in real life trials. So for me, this is something which I can tell patients. I need to deliver the trust. I need to tell my patient, well, I've got the perfect drug for you. It's safe, you don't get tired, you get fully alert, and you don't have to worry about any long-term side effects. We know hundreds of millions of people having this class of drug already. No change to placebo in fatigue, and cetirizine, as an example here, the yellow bars certainly does that. Cetirizine makes you tired. Actually, you could even say with bilastine you're even better off than before. And in CSU, you also see that the effect percentage of symptom-free patients is twice as high with bilastine in this trial compared to desloratadine and levocetirizine. So it's a very strong and very good drug, especially if you increase the dosage, which is safe with that. And that's a very important message for me. And actually, well, this is the total symptom score. Now, if we don't have success with single dose, we simply increase the dose, and it's nice to know you have this therapeutic window, you can just increase. So we suggest updosing in the guidelines, and we suggest updosing, not combining. This is relevant because you have different pharmacological properties. If you combine, for instance, desloratadine, fexofenadine, whatever, it's not good. It's better that you have one drug increase that level. And this has been tried out in trials with bilastine. This is actually cold urticaria trial where we had Peltier element induced wheels at different temperatures, and you could see complete response. Updosing helped. So from single dose to double dose, already a lot more people were free of symptoms. And this, in addition, is important. So bilastine also has an effect on cytokines, mediators released by the mast cells, which is IL-6, IL-8, inflammatory responses. This is extremely important to know that we have in our hands something which is more and giving us a real soothing down, calming down of this inflammatory process, this minimal persistent inflammation. And there's another study in chronic spontaneous urticaria, actually very similar, the dose dependency in individual patients. So you don't have to treat everybody with 4-fold dose. Some you need single dose, some you need double dose, some you need 4-fold dose, but it's an opportunity which we have. A few last words, what do we do if antihistamines do not sufficiently help? Well, we add omalizumab according to the guideline. I say a few words about that. I do know it's expensive, but it's good. It's good. It's a humanized antibody. We don't have blocking antibodies. We don't have a problem with any investigations you need to do up front. If you use infliximab in psoriasis, you have to look for tuberculosis. No problem here. And it works. 80% of patients get really good results. 35% symptom-free, 85% something really good. And hardly any adverse events. So omalizumab is a drug I like. It's allowed to use in home use in Germany. You can inject yourself as a patient Very, very convenient. And it works as well in hives as in angioedema, which again is important. So no fear of this angioedema here. There's one problem with the drug. Some patients, 30% approximately, it works like a miracle. You inject, next day, urticaria is gone. They come back, hey doctor, you're a wizard, you're great, you're wonderful. Some others, like shown in these studies, there's a distinct difference. Some are late responders. Can they be predicted? No, a little bit. If very low baseline IgE levels are there, most likely it will take longer. There is a possibility to look at the so-called basophil proteome. I can't do it in my lab. It's really only for research, so it doesn't really help. What helps, and practical tips, is this. I use this urticaria activity score defined UAS7. If you take the sum of 7 days, simply wheals from 0 to 3, itch from 0 to 3, and that's the way it looks like. I have a full month, and then I can see, well, I gave omalizumab, well, bad. The patient was bad, 3 and a 3 for itch and for wheals. Left quadrant means wheals, Juckreiz means itch. And then you see a week later, hey, he's really good, well controlled, 0 symptoms. And then, oh, Erkältung on the right side, it means common cold came up, a little bit of a flare. This is important to capture. So it's simply the disease is activated, the immune system is activated. And then it goes down again, but comes up. Aha, it's not that I look at the last days and say, hey, it's not working. No, it's been working very well, but maybe the interval was too long, or the next time it gets even longer, the interval. And if it does not work too well, but I see there is like I saw in this patient now, well, it is working, but not really all the 4 weeks. You can either reduce the interval, or in this study, they increase the dosage, and this also helped. And in real world, actually, also this has been tried. It works as well or better like in clinical trials. So for me, it's wonderful to know for the patient, be calm, I can help you. But I'm in the very lucky position of the German healthcare system, where it is reimbursed for chronic spontaneous urticaria, not for inducible urticaria. I always have to be alert. I have to think what's best for the patient. And maybe the algorithm is not best for the patient, although it's licensed treatment. And maybe I look at alternative treatments. And if you look at those, cyclosporin A, strongest evidence, of course, that's why it got into the algorithm. But others, Dapsone, cheap drug, is there. And if we look at these trials, Dapsone is something I do use, especially in those patients where there are longer standing wheals, maybe have a neutrophilic influx, very good results, but it's unfortunately not so many trials and it's not licensed. UV light, I do not use, it works. UV light is immunosuppressant, but you have the skin aging. And of course, you could just say to your patients, let's go outside, use the light, but it's not good really for the skin. Immunoglobulins, I do not use at all. They are simply too expensive, and it's too bothersome to keep them then for days, always with infusions. Methotrexate is very interesting. It's cheap. We have good results in psoriasis, and there are trials, although only one randomized control trial prospective, but it is something I would love to see more trials on, and I think many of your Indian doctors have experiences with methotrexate as a cheap drug which can support our patients. Azathioprine, I personally don't use. It's been studied in the literature, one trial, randomized controlled prospective, but no patient with complete remission. So it's, for me, it's not the real good choice. Glucocorticosteroids, I know they are worldwide, very often still used. please don't. The side effects are simply too much. Then rather go for something other cheap like methotrexate. Children, we are lucky. There's no problem. Bilastine as an antihistamine is licensed for children as well. It's no problem using these drugs in children, and they have the same level of safety. And the same, luckily, also it's true for pregnant women. We do know that antihistamines have no problem in pregnancy, and we do know that Xolair anti-IgE omalizumab has no problem in pregnancy. Cyclosporin A, well, it is used in pregnancy in liver transplant patients, but of course that's not the optimal choice. So if I summarize, and I think I've used up my time, for me, most important is good patient history. If you see there are something like a patient says, I've got reflux gastritis, I have observed always when I go and have a really good dinner on Saturday evening, I get hives increased on Sunday morning. That's a good reason to go into food allergy. That's a good reason to go into gastritis workup. Determine the threshold to know, is it getting better? Use the UAS score to know how the patient really works over time. Counsel on avoidance and prophylaxis. So really try to get in touch with the patient and use a stepwise, step-up treatment and adapt to the need of your single patient. You in your single town, wherever you are in India now, you know some areas they have a high load of parasitic infections. Other areas in northern India maybe have different problems than certainly in southern India. So adapt to the need of the patient sitting in front of you. And with that, I only can say thank you very much. It's a pity I can't see all you there in the audience. I just have to imagine you sitting and listening now. And I hope it was short enough that you still have a lot of time after our session to enjoy the rest of the Independence Day. Thank you very much for a better life with allergies from all our foundations and from the Charité Comprehensive Allergy Center. Thank you.
That was great, Dr. Torsten. We really enjoyed your lecture. And to tell you the fact that we are getting almost more than 50 patients or 50 questions already. So you've got huge number of questions which you are getting. So what I'm going to do is I'm going to take a short thing about Indian guidelines, and yeah, and then we'll have question answer. There are many questions coming, and everyone would like to know from you that what is the perspective. And so, well, Kiran Godse, I'm from D.Y. Patil Hospital. Well, coming to urticaria, Dr. Torsten has already taken a lot of things. I'll be just teaching what are the few guidelines where Indian guidelines were prepared, and they are being cited, and what is urticaria is. So typically we'll just talk about the chronic urticaria. We all know the cause is etiology, but there are aggravating factors like pressure, heat, and aspirin, and there are provoking factors like in inducible urticaria. Well, causes wise, endogenous, as we all know, autoallergy, autoimmunity, and idiopathic. These are three causes. And exogenous, we already stress upon the infection, food intolerance, allergy, and stress. So basically, it's a complex multi-factor reaction between mast cell, humoral immunity, blood vessels, inflammatory cytokines, and mediators. So it's a complex play. Well, we'll all know the urticaria is itchy, wheals, and swelling. We all know it's easy to diagnose, difficult to treat, and typically once it becomes chronic, we know that patient searches from one doctor to another. In India, patients are free to go to a doctor, so they keep on searching. They try all the pathies like Ayurveda, homeopathy, Unani, and some rare pathies, and they try, but ultimately then they come to us. So we all know that urticaria is acute and chronic. 6 weeks is the division, and we are more interested in spontaneous urticaria, where it's difficult to treat. And where we know that known causes are autoimmunity and autoallergy, and unknown causes, well, there are still unknown causes which we do not know, but now we know that autoimmunity and autoallergy are the main causes. So anything urticaria, hives or angioedema or both for more than 6 weeks is a chronic urticaria. So average lifespan has been 5 to 7 years on average. So typically patient will keep on coming to you for next few to several years. So if you treat him well, obviously patient will continue to come with to you. Now, what does chronic urticaria does to patient is, well, the relationship suffers, patient can't sleep well, they can't concentrate well, they can't work normally, they are moody, irritable, and the fun loving thing, the fun is lost, and they actually are frustrated. And if they get hives during presentation, like if I'm doing presentation, I get itching on the face, what will happen to me? So that is the same kind of quality of life. Most of urticaria patients say that, doctor, I do not want a hives on my body. Well, if patient says, yes, I can make my wheels come, then that's an inducible urticaria. The commonest in India is symptomatic dermographism. If patient can write on the skin, well, we know that if patient is symptomatic, you can give a prescription of antihistaminic. It stays there for few to several years and goes away. And most of the patient knows how to prevent it, but it is the commonest thing to have a symptomatic dermographism. Well, this is the Desi instrument of skin rhetometer for assessing the severity. Well, Frick test is not easily available in India. Cholinergic urticaria is one thing. Again, patients do get it typically in hot and humid climate, typically in October or in April, where patient gets small itchy wheals on the body, and they're typically triggered by physical exercise, hot bath, intake of spicy hot foods, and stress. So we all know these patients, they need again antihistaminics and some lifestyle changes. And this is the most difficult to treat urticaria, is delayed pressure urticaria. Delayed erythema and edema with marked swelling after pressure. Typically, lesions will appear 4 to 6 hours afterwards, and they can last up to 7 to 2 hours. So typical urticaria lesion will not last more than 24 hours. They're often itchy, painful, and burning. There could be joint pain, fever, and malaise, and they may have CSU also. So these are difficult. Typically, handbags, when patient carry the bag, tight belt, tight shoes can be trigger. Well, this is tomorrow's slide. Autoimmunity and autoallergy. These are the two things we know that can keep on triggering mast cell, and we are here to control autoimmunity and autoallergy. Well, investigation we will discuss in this thing, but typically don't load the patient with investigation. Our guidelines clearly state CBC, ESR, CRP is more than enough. And obviously you can rule out sugar and thyroid, because in India, we know that India is a diabetic capital. We have got many patients, especially in cities, so better to check sugar and thyroid. So we insist that our guidelines clearly state that basic investigation, do not do heavy tests, do not do prick test, don't do the allergy test routinely in the patient, but the basic tests are sufficient for most of your patients. And urticaria activity score is a simple score, and we have this is on the urticaria app also, and it's simple, just count the number of wheals and the severity. Maximum is 6 per day and 42 in a week. So you can understand the patient has got a severe urticaria or mild urticaria. So wheals more than 16 are considered to have a moderate to severe urticaria, and less than 15 are mild urticaria. So this is easy to diagnose, control, and we can always judge the patient how bad it is or how good it is by doing this test. Urticaria control test, again, it's a simple instrument, just 4 questions, and it is there on the app. You can just ask questions, and if you get answer, total score more than 12 means a good control. So this is again easy to do in your clinic. Just again, many companies have provided this UCT meter to you. Well, we always say urticaria is like a burning train. You know, our job is to control the fire, but we can't stop the train from burning or going ahead. So typically the course is there for few to several years. Our job is to control the fire and let the journey be safe. So as I told you, that urticaria can stay for 5 to 7 years, but at the end of 1 year, 50% patient will be free. So we always tell the patient that urticaria is a disease, autoimmune etiology. You need to take a long treatment, and most of the antihistaminics are safe. And at the end of 5 years, again 20 to 50% will disappear, but 2 to 5% will have urticaria up to 25 years. So this is the lifestyle of a urticaria patient. So patient coming with 3 months of urticaria or 6 months of urticaria, you can always tell them, look, take the treatment regularly, and at the end of 1 year, you will be free of the disease. But which are the patients which will trouble you a lot? Well, these are the patients, those who have got urticaria activity score of more than 15-20, females with higher age, concurrent angioedema, inducible urticaria, a positive autologous serum skin test, and now a metabolic syndrome, hypertension, and NSAID hyperreactivity. So these are the patients will have urticaria which needs more than antihistaminics, and typically they need sometimes cyclosporine or omalizumab also. Well, these are the oldest 2011 concern statement which was released, and Well, it was again an inspiration from Dr. Zubair Baran's team, where we attended his urticaria guidelines in 2008, and then we started this. Then we attended 2013 guidelines, and now it's a 2016 revision, which is already there. Doctor has discussed, and we are excited that in 2020, in December, just 3 months from now, we'll all again meet and again scratch your heads and say what is the best one, what is the evidence, and we'll all fight. We'll say yes, no, we'll raise our green card or red card, and finally we'll come to conclusion, and the new guidelines will be released. So I'm very excited for getting a new guidelines for urticaria, and that will be in December 2020. Well, the EACI guidelines are known as the world guidelines because they are being endorsed by more than 30 societies. And let me tell you that IADVL is the society which has endorsed these guidelines. And to tell you the fact, as a president of IADVL on 1st of October will be celebrating Urticaria Day. So all 12,000 dermatologists will do some activities to raise the awareness of urticaria. And it's the first time happening that world's second largest dermatology association will be celebrating Urticaria Day on 1st October. American guidelines are on the screen, where it is almost similar, but there they have added a potent antihistaminics like hydroxyzine and doxepin as step 3. And they also added H2 antagonist and montelukast in step 2. So typically rest all remains same. So obviously these are more on the experience, whereas the EACI guidelines are more on the evidence. So what differs with the two is the pseudoallergen diet is mentioned in our EACI guidelines, whereas the first generation antihistaminics are being mentioned in the American guidelines. So obviously you can choose, but our request is should not that hydroxyzine should not be given to all the patients. It should be reserved for some patients who have difficulty in controlling the urticaria. Then our second consent statement was released in 2018. Again, it was on similar lines of the world guidelines. But here we say that strong evidence is for cyclosporin and omalizumab, and weak evidence was for hydroxyzine, methotrexate, autoserum therapy, and doxepin. So again, doctors can choose what is best for the patients, and they can come give the patient relief. Typically, all patients you need to start antihistaminics 1 tablet. If they do not respond, you make it 2 tablets. If they do not respond, you can make it 4 tablets. Remember, 1 tablet of antihistaminics will control only 50% of urticaria patients. When you give 4 tablets, it is almost 80 to 90% of patients will show a good control. So this is important that last 10% of patients will need something beyond that. That is a step 3, that is either cyclosporin, omalizumab, or this thing. Well, this is a table X where only trials of low quality or case series have been published. So Dr. Torsten has already discussed few of them. So I'll just be telling you, well, now it is accepted that the updosing is the stay. So you can give 4 times the dose, and we have got many studies to say that it is a dose dependent action, toxicity is low, and there is a potential anti-inflammatory effect when you raise same antihistaminics 4 times. Well, omalizumab is discussed. We know it works. It improves quality of life. It works as long as you give. It does not give a cure. And now we have got a biosimilar of omalizumab available in India, which is little economical, but obviously still every patient cannot afford this. We can actually predict who are going to respond well. So typically good, very low baseline serum Ig level should be in hundreds, and typically with the low D-dimer levels and no concomitant ACE inhibitors. Well, montelukast, selected patient like those having a respiratory allergies or those having NSAID-induced urticaria, you can give montelukast. H2 antihistaminics were there in the last guidelines. We are not there in here, but those patients who complain, you can give ranitidine 150 mg BD. It is available in India easily. So after 4 antihistaminic tablets, you can try ranitidine if patient has the complaints. H. pylori, typically we don't do routinely in India because some of the Indian waters contains H. pylori, so it's very difficult to eradicate unless our gastroenterologist friends say that you need to give H. pylori kit to eradicate H. pylori. Well, cyclosporin is the one which has got rapid action, good efficacy, and may induce remission, again 2 to 4 mg per kg. But in these COVID times and Corona times where we should not give high dose of immunosuppression to the patients. So typically, if at all you have to give during these COVID times, you insist that don't give more than 1 mg per kg because higher dose, his patient is good prone to COVID. So again, immunosuppression should be used judiciously during these COVID times. MMF, well, it can be given as immunosuppression 1 to 2 gram per day. Methotrexate, well, it is Indian studies are there. We can give up to 10 to 20 mg per day, per week, and folic acid. It works as an immunosuppressant. Action is slow, not as fast as cyclosporine, but again, most of the patients do treat this again, and we Indian doctors know how to use this because of in psoriasis we use this routinely. So this is the second option if patient can't afford omalizumab or cyclosporine. Dapsone is again we know to use it in leprosy, so 100 mg per day you can give typically in urticaria vasculitis, and in urticaria those who are not responding, after you give 4 tablets of antihistaminic you can give Dapsone to see. Phototherapy, well, it works, but patient need to come. It's a costly therapy, so again, not routinely used. Well, this is the Indian auto serum therapy. It's an poor man's biologic. We give repeated injection of serum intramuscular or subcutaneously to desensitize the patients, and it can be given 2.5 to 3 cc every week for 9 weeks, and 1/3 patient will definitely respond. And our Indian patients love injections. So again, this is a good therapy for Indian patients. And what you need is a minimum instrument, just a centrifuge and sterile syringe needle and injection. Well, how long to give? Well, as much as needed and as little as possible. This is the tagline of urticaria guidelines that you need to give. You can't say stop. Gradually you reduce. Don't try to reduce very fast. If your patient is updose, you make it reduce every 2 months. Don't be in a hurry to reduce, and treatment is going to stay for few to several months. So tell the patient that, well, treatment is safe and you can take it. Well, if you want to know more about urticaria, you can join a digital meeting on 4th October on Skin Allergy where urticaria is there. And I think, yes, we have got enough time. I've just finished my lecture. So thank you very much. This is where I took over as the IIDR president in 2020 Pune. So thank you very much for listening. And now we have got lots of questions, which I can see under my chat box. So I'm going to ask, and me and Dr. Zubair Bhai is going to discuss and see. So Torsten, be ready because there are many questions coming from all over India. It is from Srinagar to south to west. We are getting lots of questions. So we will be asking you a few questions. So obviously you can read. Yeah. There are so many questions, but I will be just combining few questions and asking you because we have around 15-20 minutes to this thing. There is one question where they use that you said that Bilastine can be used in children and in pregnancy and lactation also, or what is your views on children? Because the syrup Bilastine is also available now in India.
Kiran, do you want me to answer that question?
Yeah. You are the expert. Means obviously I will also answer, but they want to know from the expert, like Bilastine syrup is available in abroad, even in India also.
Yeah.
So how do you use it?
Actually, I can tell you it's safe to use at any age, but I don't know if the syrup is available in India at the moment. I think so, yes.
Yeah.
Kiran, please help me.
Yeah. So, and can Bilastine be used in pregnancy and lactation?
It's pretty simple, the answer. It's not licensed like any of the antihistamines. We have the highest knowledge on pregnancy with loratadine and desloratadine, 300,000 pregnancies which have been followed. There is not a logical reason why Bilastine should be different from that, but it is always a single decision by the doctor because you always have to abide to the law. In pregnancy, you have to make a very good decision point, and I don't see any problem at all. But if you want to be on the safe side, you have to say the highest knowledge is about loratadine, desloratadine in pregnancy.
Right. So there is Dr. Masoor Ahmad from Srinagar, that is Kashmir. He's asking, how safe is Bilastine in the cardiac patients?
In what patients?
Cardiac patients, heart patients.
Okay, no problem at all. That has been tested in high doses, that there is absolutely no action on any cardiac receptors. No cardiac problems have ever been reported, and we've been using 4-fold dosages, 2 times 2 tablets, morning 2, evening 2 of Bilastine for a long time. I have hundreds of patients. I haven't ever seen a single side effect.
Yeah. So that is important. And somebody asks how to give Bilastine. You can give 1 BD, 1 tablet twice a day, or 2 tablets twice a day. So that is the best.
It actually wouldn't matter in the long run.
Yes,
but it's easier for the patient 2 in the morning, 2 in the evening, because people are people, and sometimes they forget a dosage. So it's easier then, at least they don't have forgotten everything for the day, but only half of it for the day.
True. So again, this was one more question. Yeah, again, Dr. Pawan Yadav from Ghaziabad, UP. Now we are getting questions from all over India. How that bilastine is better than the other anti-allergic drugs? What are the points which you say that bilastine is better than other drugs, other antihistaminics?
Okay, to be clear, honest, and precise, we have other good antihistamines which have been developed. There's loratadine, fexofenadine. Cetirizine has a problem. 10% of the population have a weaker brain barrier, and it has a higher effect in those patients who have a weaker blood-brain barrier. Sorry, my son is always changing the light. I suddenly get in the dark. I don't know why. It's the sun in Germany. So, if you see the slides I showed, bilastine has two advantages. It's the antihistamine which has the lowest permeability through the blood-brain barrier, actually zero, actually even minimal minus. So it's really actively pumped out from the blood-brain barrier, doesn't go into the brain. This is an advantage. The second advantage is it is currently the strongest antihistamine on the market. This does not mean that everybody needs it, but you will certainly see it. Some patients on a single dose of desloratadine have no effect at all, but have a huge effect on a single dose of bilastine. And other patients who have a mild symptom, they are doing fine with a single dose of desloratadine. So it's the strongest and it is the safest regarding blood-brain barrier.
Great. So, well, many things are getting clear now. This is from Dr. From Mumbai, Dr. Sujata. She's asking, is there a step-down process? How do you reduce antihistamine? This patient is on bilastine 1 BD and is controlled. When do you try to reduce? Because she says that if I try to reduce fast, patient gets again flare. So when do you reduce if patient is on 1 tablet twice a day?
It's a clear question of pharmacoeconomics. You use only as much as needed. And we will have in the next guideline, I can already predict, we will have a kind of step up, step down procedure like in asthma. And we often have patients, like you said, with cholinergic urticaria also, where there is a difference. If it's a high temperature, humid day, you will have more cholinergic urticaria than on a winter day, potentially. And that means, first of all, I treat most patients I start rather taking 2 times 2 tablets, have success, and then level down, but tell them minimum is continuously 1 tablet due to this histamine receptor upregulation.
Right.
We want to have total symptom control.
Symptom control, yeah. So don't be in a hurry to reduce, gradually reduce, and obviously patient need to continue drugs. We cannot stop it suddenly. Well, there is one question that how can you differentiate autoimmune urticaria from non-autoimmune urticaria? Is there any special test apart from ASST? Anything else we can do?
Clear answer, no. The only thing what we have is the autologous serum skin test, which is not very practical. It's time consuming. You're not getting reimbursed for that. And in fact, it doesn't really matter because you still have to do the workup because cofactors can exist. We have patients where the autologous serum skin test is positive, but they got totally good on diet. So it's not excluding that. And the treatment is exactly the same. So I do use it sometimes. I do use it for research, but in clinic, I use it then to show the patient, well, he wants to know, is there any reason, doctor? Yes, okay, we've got the autologous serum skin test positive. Then I can tell the patient, yes, we found the reason, but now we have to cure it.
Right. So typically, yes, there are a few more questions coming. We have still time. Yeah, now coming to the question about the injectables. Well, this is about the omalizumab. Doctor is asking, how long can I give omalizumab? And any side effects apart from the reaction?
The good thing about all drugs we have discussed is there is no tachyphylaxis. That means from that point of view, no problem. Second good thing is neither for bilastine, antihistamines, nor omalizumab, a single side effect as a long-term side effect has ever been described in the literature. Next, very important message, we now have a lot of patients which we looked at in the UCARE network of Galen, where Kieran, you are a member, who have had COVID-19 infections. No problem with omalizumab or antihistamines like bilastine. It doesn't change in any way the immune system being dysfunctional. So it just balances the immune system in our urticaria patients.
Right. Just this is about omalizumab in India. Now we have in India a biosimilar of omalizumab is also available. Well, patients, it is little economical than the original one, and patient can take either one. Typically, you have to take it every 4 to 6 weeks, and patient pays from his pocket, except government employees get it free. Well, patient can be slowly. What we do is we give it once a month for 3 to 6 months regularly, and then try to increase the interval between the two injections, so that patient knows when he start getting hives, he takes the injection, and that's how patient controls. And obviously, it is safe. Well, in India, till the home-based treatment is not advisable, so we tell the patient to come to hospital, take injection, wait for 1 to 2 hours, and then go back. So that is the best way to give. And now we have a option of this thing in COVID times, when there's a COVID infection, when we cannot give cyclosporine or very high dose of methotrexate for fear of immunosuppression. This is the best choice for the patients. And most of our patients who are on omalizumab are continuing it despite the COVID infection, whereas all our patients who are on methotrexate or on cyclosporine, we have told them to reduce the dose as much as possible, but that sometimes becomes difficult. So that was a thing on Indian perspective of omalizumab. And yeah, doctor, I heard about the legelizumab. Somebody is asking you what is new in that new molecule. Can you tell us a short?
Yeah. Also, we at Charity, we are part of the study team of ligelizumab. Ligelizumab is what you could say the super omalizumab. It's an anti-IgE antibody, which is simply much more potent than omalizumab. So the results are better, and the first published results show that omalizumab is less good in a head-to-head comparison. So ligelizumab is the better omalizumab. This, of course, does not mean if it's licensed, we know it will be more expensive than omalizumab, and there will be generics biosimilar to omalizumab in the future. And this does not mean that everybody now needs to get ligelizumab. It's rather those patients who do not get better on omalizumab we have with ligelizumab, but also with other drugs now in the pipeline, new possibilities to deal with that. Actually, Kieran, I also see there's a special question about cholinergic urticaria, how to treat that. Shall we answer that question?
Yeah, please. I'll be happy. There are so many questions. I'm just choosing. You can ask. Please, we're interested.
I like these questions about the chronic inducible urticarias, because here we have an additional possibility. In some patients, you can really get a kind of, let's say, desactivation, not in immunotherapy, but a desactivation. Like in cholinergic urticaria, it's been described, if you more often a day just get yourself at the limit, take a hot shower in the morning, do a bit of exercise, but just at the limit, then the system will slow down, because the mast cells simply have been releasing all their mediators. And in some patients, this is a very nice way, in combination with antihistamines, to keep it at bay. The same holds true for dermographism. If you scratch the skin with mild, let's say, sub-threshold itching, scratching, you may get over that. And on the other hand, of course, it's important for the patient to know the threshold. That means in, let's say, cold urticaria, which is relevant in northern India in winter, then you know, okay, I can stand 15 degrees Celsius no problem, but 10 degrees with wind is a real problem, and I know the time. So helping the patient, then getting some support, or with pressure urticaria, you can help a lot with cushioning at the right places and explaining to them. So I think this is an interesting setting.
Right. That is interesting. Now somebody is asking, can we use bilastine in the morning and hydroxyzine in the night? Those who are not controlled with 4 tablets of bilastine, can I use hydroxyzine in the night?
Yeah, I just see that question. And in fact, well, you can do it, but it is not as good. I personally would not do it, because you really have the problem then that you sedate the patients and that the REM functions and the cognitive functions go down, motorway accidents. You have to explain to the patient not to drive the car on the next day. But there's no rule against it. It's possible. And actually, I see 2 interesting questions also, Kiran.
Please
There's
take
one question: do you suggest IgG food allergy test? No, please, no. This is real crap. This is deceiving people. It's taking money out of pockets of people. You always find an IgG reaction against food in everybody of us sitting here or listening to this presentation. It is fraud. It's not helping you for urticaria, and there are investigations and scientific publications on that. Interesting is the question about omalizumab effective in pemphigus. It's rather pemphigoid, bullous pemphigoid, where IgE is playing a role. Some patients with bullous pemphigoid get good on omalizumab. Yes.
Right. So, well, it works omalizumab in bullous pemphigoid and not in pemphigus, but yes, people can try it. Well, there are a few more. We have got the last 2-3 minutes left for our session, and yeah, I have got many questions. Well, there is one question by best treatment for alcohol-induced urticaria. Many patients complain of if they take alcohol, they get urticaria. From Dr. Katkar from Mumbai. How do you do that?
Code?
Alcohol, the whiskey or wine can cause urticaria.
I'm sorry, I have a little bit of problem with understanding.
Yeah. No, it is
from cool air.
No. It is for the alcohol. If patient takes alcohol.
Okay, now I understand.
Sorry,
that's an interesting question. Okay, it's true that alcoholic beverages in general increase all allergic symptoms. They simply make the blood vessels wide, and histamine can get more easily outside. And we all know in our rhinitis patients, some get blocked nose from alcohol. So this is the one aspect in everybody. There are a few patients who really have hives only when they drink alcohol. And some of them, again, 2 subgroups, some of them have it independent what kind of alcohol. It's just the ethanol itself. It's called ethanol intolerance. Others have only a reaction to specific alcoholic beverages like beer, where you can then potentially find an allergy against the yeast in the beer, a true IgE-mediated allergy. But if you're unlucky and you have a true ethanol intolerance, there are only 2 options. Don't drink, or take an antihistamine like bilastine and then look at the threshold.
Right. So, well, such patient, you can change the thing from wine. Many times wine also can cause urticaria because it is known. But obviously you can take antihistamines and try. That is the solution from this. Yeah, we have got just last 1 minute. Well, we have got lots of questions, but we need to stop. Dr. Zubair, we are very much excited for the urticaria guidelines, which will be held in December. And if the corona permits, most of the Indian dermatologists would like to come also. So just tell us about these guidelines, and so please invite us. We'll hopefully things are better.
It is a great pleasure to tell about the guidelines. We do expect that many of the countries are able to travel in December, and that we do hope that of the now nearly 50 delegates of different societies all around the world, we will have a good attendance. And I really do hope, Kiran, you yourself will be able to come. But in case it's not possible, we will have the possibility to have an online attendance also. And the guidelines will change. There is new evidence coming up. And what we do need to, let's say, take a bit more into consideration to be more flexible in the algorithm. I know countries like India need a different approach than Europe. And we do need to make more statements on the alternative, cheaper treatments to also rank them. What is best, in which order to go, and not just leave the people alone.
Yes, great.
But
So we are
I'm
excited.
excited.
Yes, as well. Thank you. We have been attending these guidelines since 2008, I believe, and we have been learning every time. And we hope to learn from this time also. So I think that was a wonderful session. We have got lots of questions. Few are still not unanswered. We'll try to answer it in another session like this. But again, Dr. Roshan, it was wonderful to have you here and speaking with us. But you can't hear our claps, but well, it was one of the best lecture and best discussion which we had, and we all had clapped. Well, now I hand it over to the team to offer vote of thanks. Thank you, Roshan. Thank you, viewers.
Thank you. Do you know how many people have listened?
Yeah. She, Dr. Dipali will told. They are almost. Yeah, doctor, tell me.
So we are more than 438 people who had registered.
Good.
Yeah. Thank you. Sir.
So thank you very much, Dr. Zubair and Professor Dr. Kiran Godse. There is a very good talk, basically in terms of the clinical management of the urticaria. So questions are also very well addressed in terms of the clinical practice, and we hope that all our dermatologists get the good information about management of urticaria, and they will use that information in their clinical practice. So thank you very much, sir, once again.
Okay, thank you. Bye.
Thank you very much, sir, and thank you, doctors, for watching. Thank you.
Thank you, everybody. Have a great evening ahead. Bye.